Okay.
Right.
Hi, everyone. Stephen, hello.
Christine, hello. How are you?
So let's introduce ourselves to the audience.
My name is Stephen Liu. I'm a medical oncologist from Georgetown University in Washington, D.C.
And hi, everyone. I'm Christine Lovely. I am a medical oncologist from Vanderbilt University in Nashville, Tennessee. Thank you so much for joining us today. And do we have a sense of how many people are online right now?
About 150.
Wow.
Amazing. Hi, everyone. I'm sure you're joining from all over the world. Thank you so much for being here with us today. All right, we're going to jump right in, Stephen. Oh, my microphone is... we can't hear Dr. Lovely very well. Sorry about that. Okay, we're going to fix that.
We're good. Go ahead and introduce yourself again real quick.
Okay, sorry. Christine Lovely. Hi, everyone. Sorry for the microphone challenge. My name is Christine Lovely. I am a medical oncologist from Nashville, Tennessee. And sorry, which camera are we looking at? Okay, wonderful.
Oh.
I was like, Stephen, why are you looking up there?
I don't know.
It's like you'd never done this before.
I can't see myself. Yeah. All right.
Okay, let's jump in. So, Stephen, I'll read the question and maybe you take it and we'll go back and forth.
Okay.
Is that cool?
Yeah.
All right. So, 62-year-old female diagnosed in May 2019 on lorlatinib since August 2019, 100 milligrams per day, very few side effects, almost 6 years and doing well. The disease has been stable for some time now. What is the longest known documented case of PFS to date on lorlatinib? At this point, is it still possible for my disease to metastasize to any other sites, i.e. bones? What next steps are available to me in case of progression? Deborah, thank you so much for the question, and I'm going to let Stephen answer it.
Well, congratulations. I think it's a great response, and our hope is that it's one that just continues. I think there's no limit as to how long a drug can work. And while we look at medians and averages as just a way to process the information, sometimes it's just the perfect fit and the medicine keeps working. It doesn't mean that we have to stop watching it or we get to stop watching. You always have to watch. And I would continue doing scans, radiographic monitoring. And yes, it is still possible for the cancer to spread to other areas. It's something we're still trying to understand how that happens. Next steps that are available. Well, there are several different clinical trials. We've heard from the Nuvalent compound, NVL-655, that's being developed. But there are other compounds, new antibody drug conjugates, new chemotherapy strategies. And if lorlatinib were to stop working, if we saw a new area of spread, a new area of growth, it was just one spot. We might think of radiation to that one spot, even surgery to that one spot, and continue lorlatinib. I think there are a lot of options if the cancer eventually does show signs of progression. But hopefully the response continues. So congratulations, it's a great response. We'll go to this next question, which is one we answered earlier, Christine. How often should follow-up CT scans be performed? Should they be with or without contrast? And then Guido mentions their mother also undergoes a PET scan each time. Does that make sense medically or is it unnecessary? A lot of great radiographic questions there.
Yeah, so Guido, thanks for the question. This question, it has to be tempered by at what stage of disease and what point in treatment. And so let's take an example of a patient with stage 4 lung cancer who is maybe 6 to 8 months into their treatment. Usually I'm getting scans every 3 months. I monitor with CT scans, not with PET scans. CT scans are higher resolution than PET scans. If there's a problem on a CT scan or something comes up that looks a little weird, I may get a PET scan in that circumstance, but I do not routinely surveil with PET scans. The question of with or without contrast is also going to be dependent on a lot of patient-specific factors, where their disease is, what their kidney function is. And so I'd say in general, I'm getting my CT scans with contrast, but that is not an absolute hard fact. It really is dependent on the specific patient, and there are other medical factors that may make contrast more or less difficult to administer. Okay, next question, because we had a lot coming in, which is awesome. Keep them coming. Let me see, I lost my spot. Okay, Leslie asks, I'm a 10-year survival of stage 4 ALK positive lung cancer. Amazing. I have progressed 3 times in the brain. I progressed on my second TKI alectinib and developed LMD. So for those who don't know, LMD is leptomeningeal disease. That is cancer around the lining of the brain and spinal cord. Went on Lobrena, lorlatinib, and it resolved. Can the LMD or leptomeningeal disease recur? Does NVL-655 fight LMD? Wonderful questions. Leslie, thank you for sharing your story. Stephen, I'm going to throw this to you.
Yeah, I think leptomeningeal disease is something that unfortunately can recur, and so it needs to be monitored very closely. NVL-655 is an effective treatment in settings of LMD. We don't know a whole lot about its efficacy in LMD after lorlatinib. It's something that's being studied now in the ongoing trials. But it's an area we have to watch, and I will admit it's an area where we need more research and more drugs, and so hopefully we'll see more studies looking specifically at LMD across the board. But lorlatinib is a very effective agent in that setting, and our hope is that response is very durable. Yeah, they're moving pretty quick.
Yeah, Victoria.
Victoria asks, do you typically always recommend cytology on a new pleural effusion regardless of size? We're talking about a newly diagnosed stage 4B on alectinib for 4 weeks, but being held due to a new effusion and in the process of switching to lorlatinib. A tricky one, Christine.
Yeah. Okay. So, hi, Victoria. Thank you for sharing your question. If it is a new effusion, a brand new effusion, wasn't there before, I would definitely send cytology. If a patient is having recurrent effusions, like they had an effusion and I sent it for cytology and it was known to be positive for cancer, and they're having to get repeat drainages, so like every couple days or every couple weeks, then I don't send it every single time in that case. But if it is a brand new effusion, or if the patient's effusion resolved and then many, many minutes later it came back, then I would send cytology at that time. So they're not a hard and fast, yes, send cytology every single time, but in general for a new effusion, I'm sending the cytology. Okay, next question. We are on Ken. Thoughts on reducing blood thinners after 6 months with no clots and no heart issues?
Well, my hematology board just expired, but I was once a hematologist, and we use blood thinners really in this setting to treat blood clots. And the duration of treatment really depends on why the clot developed. If we have a blood clot in the leg after surgery, we might treat that for 3 months. But we know that lung cancer is a risk for blood clots, and if the body reacts to a cancer by developing a blood clot, as long as that cancer is present, that risk still exists. And so in those cases, we often continue the blood thinner as long as it's tolerated, and sometimes for life. There are some data that we can drop the dose to maintenance doses in settings of low risk. Those are mostly from the atrial fibrillation handbooks, but I do think it's in some instances after long periods of time we can drop the dose, but you got to talk with your doctor closely about that. Let's go to Peter. What length of time between MRI scans? What would trigger an MRI scan after having just a CT scan?
Okay. Hi, Peter. Good question. So this depends on if the patient has cancer in their brain or not. And I would treat the duration or the interval between MRIs differently depending on if the patient has cancer in their brain or not. It may also differ, clinical trials, we're going to put that aside because clinical trials are going to have a different regimen for obtaining the MRIs. If a patient has cancer in their brain, I might be getting the MRIs of the brain as often as every 3 months, depending on what drug they're on and how active that drug is against cancer in the brain. If a patient doesn't have cancer in the brain, but I'm surveilling the brain, then I'm usually getting it around every 6 months, especially if it's close to diagnosis. The further away we get from diagnosis, if we're years and years out, I may space it out a little bit, but it depends on the stage, the drug, the timing of the treatment. But I think the most important takeaway message here is, particularly for ALK-positive lung cancer, it is important, even in the absence of known cancer in the brain, to be looking at the brain.
And I'll also mention that a CT scan of the head is not the same as an MRI of the brain.
Not equivalent to an MRI of the brain. Yes, thank you, Stephen. Okay, where are we? We are... Todd. Okay, Todd. Do you need to take a TKI at the same time each day? If you take it with dinner, but sometimes eat at 6 and sometimes at 8, is that an issue?
Oh, this is a great
very good practical question. Yes,
yeah.
I like it, Todd. Thank you.
I would say it's not an issue. I think that if you take it about the same time, that's okay. And I don't think you need to structure your life, step out of a movie, excuse yourself from dinner, for example, to take the medicine. I don't think it needs to be so precise. This is a medicine that hopefully we're taking for many, many years. I have patients who sort of travel around the globe and then they drive themselves crazy by looking at time zones and trying to calculate exactly when to take it. I think about the same time. I think you can give yourself a little bit of grace, and a few hours will be okay, I think, each day.
While we're talking about travel, let's mention this, Stephen, for everyone who's listening. If you do travel, please make sure that you travel with your drug in your carry-on package, because these are not drugs that we can just dial up CVS or Walgreens or Walmart or Target and say, hey, send out the alectinib or send out the lorlatinib. So very important, even more important when you're traveling internationally, bring your drug with you on your carry-on. Make sure you remember to bring it. Most people do, but I've definitely had circumstances where, oops, I forgot it at home. And it becomes a challenge to try to get it, especially if you're international.
Yes, very good point.
Next, I think we're at Jeffrey.
You may have to skip some just so you get 10 more on top of these.
Okay.
Okay.
You got to go faster, Stephen.
Okay.
Talk faster.
Stage 4, metastasis to lymph nodes, pleura, lung, ribs. Would you recommend alectinib or lorlatinib as first line, no brain metastases?
Okay, my practice right now, Jeffrey, thank you, is I'm using lorlatinib in the first line unless there's a compelling medical reason not to. So regardless of where the metastases are, my first line treatment of choice for patients with stage 4 ALK positive lung cancer is lorlatinib. Okay, Eve to everyone. Unelective under 5 years, stage 4B, NED for 4.5 years, surveilled benign pancreatic tail cyst on CT scan. That's pretty common. Mild increased size of the branch duct type IPMN in the pancreas tail. Now, again, not too uncommon. I see this, several patients. High risk features for malignancy, endoscopy, ultrasound, and schedule. Thoughts?
Yes, I would do the endoscopy and ultrasound. It wouldn't, in my mind, be related.
Yeah.
But I would say that being on alectinib doesn't protect you from other medical events. So I would pursue biopsy and have whatever treatment's needed for that.
I'll use this time to very quickly say another message, which is please make sure that you have a primary care doctor and that while you're getting your cancer treatment, that you're thinking about things like blood pressure, pap smears, mammograms, all of the normal things that you would get that are age-appropriate screenings for your normal health care, because we don't want to throw the kitchen sink at the cancer for diabetes to get out of control or hypertension to get out of control, and some of the things that we're not necessarily can't or don't have time to always address in a cancer clinic. Please make sure that you're staying in close communication with your primary care doctor as well.
Yeah, that's hugely important. And don't let a doctor not pursue a standard workup because you have lung cancer.
100 billion% agree.
Right?
Happens all the time.
They'll say,
I always tell people, I own the cancer. You tell your doctors, they worry about everything else.
Yeah. What would you do for someone that had no cancer at all? And if they said, oh, this is suspicious, we would biopsy this pancreatic lesion, but there's a history of lung cancer, we're just going to forget it because you got to deal with the lung cancer. That is sort of this nihilistic old approach. They should ignore the lung cancer and just focus. What would you do if there was no lung cancer? Would you biopsy this? Then biopsy it.
100 billion% agree.
All right, Christine. What can we do as patients to improve the effects of drugs in terms of diet, sports, or supplements?
Okay, so great question. I think there's always this, what can I do proactively to improve my wellness? So I can't say that there's going to be anything necessarily to improve the effects of the drug, although I will say there are things that can make the drug worse, which is if you're taking a lot of other medicines, either prescribed medicines or supplements, please tell your doctor that what you're taking. And the reason I say that is not to pass judgment on if you're taking supplements, but rather we need to know if there's drug-drug interactions that may inadvertently be lowering the dose of the drug that you're taking. This is really important. Even over-the-counter stuff, vitamins, whatever, however benign you think it may be because you bought it over the counter, I want to know about it just to make sure it's not actually lowering the dose of the medicine that I'm giving you for your cancer treatment. So wellness, huge topic, really, really important. Can't say anything specifically for ALK positive lung cancer, but I would say for cancer in general, and not even just for lung cancer, is diet and exercise. This is true for all of us in general. Making sure we're eating green leafy vegetables, making sure we're getting enough sleep. That is unbelievably important, and most of us don't get enough sleep. Sleep is important. Diet is important, and exercise doesn't have to be something super strenuous. Walking, light weightlifting, whatever works for you. I think the most important thing is we all have to find something that works for us, because if we don't like doing it, we're not going to do it. But just thinking about it, incorporating small things, 5-minute walk here and there, sleep, setting small goals, really, really important. Okay, next question. What happens, Sly? What happens with ALK cancer if you're on a break? 3 years stable, 3 weeks off for side effects and stomach flu. I have seen some people take 3 months break each year.
Ooh. So I think that short breaks periodically are okay. If you have stomach flu, if you have COVID, if there's some medical emergency, like you have appendicitis and go into short breaks like that are totally okay. But I would discourage someone from taking a 3-month break or long breaks for a couple of reasons. One, there's the possible risk of what we would call a flare, and we learned this the hard way early on in studies, that when we're suppressing a cancer with an effective drug, it looks like everything's under control. When we stop that medicine, sometimes those cancer cells come roaring back, and that can cause a lot of problems. We don't want that flare, that sudden burst of disease, but also there's a concern that if we take long breaks of treatments, that it can sort of promote resistance a little bit earlier. So this is a treatment that is designed to be taken every day, and I think that's the way in which it works best, and I would do that. If you find that you need to stop very frequently for side effects, it might mean that you're on too high of a dose or that you're not on the right medicine.
No, nothing to add. Let's keep knocking them out, Stephen.
Okay, we were on
Wing.
Hi, nice to meet you. My mom, 70, just diagnosed June 2025, had brain spread, did gamma knife for 5 spots, palliative thoracic radiation, then got on alectinib just over 2 weeks ago. Should she really be on lorlatinib? So I guess the question really is about switching from alectinib to lorlatinib. Christine?
Yeah, so this is a good question. I would say, it's hard to comment specifically for your mom's case because there may be a reason her doctor prescribed alectinib over lorlatinib, a medical reason that I just don't know about. I will say in my practice, my standard first-line treatment for patients with stage 4 ALK positive lung cancer is lorlatinib based on the study called CROWN. It is, they were never and will never be compared head-to-head, alectinib versus lorlatinib, but I usually start with alectinib or lorlatinib because of the effect of this drug in the brain to both treat and prevent brain metastases and the long duration of time that patients can be on lorlatinib. Now, I temper that with there may be a reason that your doctor chose alectinib that I'm not aware of, so I will just comment on my standard practice right now. Next question. Gaurav, is there a place for clinical drug screening assays and management? If responding to lorlatinib but MET inhibitor showed an even better response than lorlatinib in the assay, would you add it to the lorlatinib therapy? How about if you see relapse of the tumor?
So I don't think there's a role for these in vitro assays. We're referring to tests where you take the tumor out, you grow them outside, and you treat them with different medicines in a laboratory. For lung cancer, those haven't translated well to sensitivity. They haven't been great predictors. And so I think those in vitro sensitivities don't translate well to in vivo, to in-person sensitivities. And in this setting with an ALK fusion, I would not switch to a MET inhibitor, add a MET inhibitor at the beginning. If lorlatinib's working well, I would stay with that. Christine, from a lab standpoint, anything to add?
Yeah, I think, these are the types of experiments we do in the lab all the time, but I would not do that. It's not standard of care and would not be supported by data and frankly may not even be supported by a patient's insurance. And so it would be hard to know if it's even working, if it's better than a double drug combination in this setting is better than a single drug combination. How would we know it's better than just the single drug combination? So I would hold and potentially use options at progression.
For patients who jumped to NVL 655 after alectinib and skipped lorlatinib, is there any hope that lorlatinib could work if and when chemotherapy fails? I experienced progression with NVL, currently on chemo, never had lorlatinib. Can you go back to lorlatinib after NVL?
Yeah, I mean, if that is a question at the cutting edge. I don't think it's unreasonable. I would certainly consider it in my clinical practice. I would love to get tumor sequencing and liquid biopsy to say, for example, is there an ALK resistance mutation that may support or push me in favor of using lorlatinib again? But if I'm thinking about what are the tools that I have in my toolbox, I would consider lorlatinib one of those tools in this scenario. I kind of think about chemo as wiping the board clean and resetting it. And so I would definitely consider lorlatinib as an option here. All right, Linda, what is your opinion on the use of GLP-1s for weight loss and the interaction with TKIs?
So weight gain is unfortunately something we can see with a drug like lorlatinib. 25% will have grade 3 weight gain at 5 years. And so that is significant. Can we use GLP drugs like semaglutide and others to balance weight loss? There was a publication this year from Marina Garasino's group at the University of Chicago showing that it was effective in balancing that weight loss. So I don't have any concern. I'm not aware of any interactions with TKIs. I think it's a very reasonable thing. I will say that for a few of my patients where we've explored it, I haven't been able to get insurance to cover it. So that unfortunately remains a challenge in terms of financial. I think the drugs are very expensive. They're not always covered, but in principle, I don't have any concern.
Agree. Yeah.
Okay. Friend is on alectinib and just found 10 spots to the brain. The plan is to change to lorlatinib and CyberKnife, 2 spots near the midbrain, I think 4 millimeters. I just heard in the last talk about radiation necrosis that can occur 1 to 2 years later. Can this occur for any size? Great question.
Yeah, so good question. Radiation necrosis is a more of a long-term side effect from radiation to the brain. I would say the radiation oncologists are outstanding at trying to mitigate this potential side effect. There are treatments for radiation necrosis, and some of the drugs that Stephen and I use in our practice, something called bevacizumab. There's no way to predict it. I think the more a spot is radiated, the more likely that radiation necrosis will occur. I think the fortunate thing here is lorlatinib is extremely extremely effective in the brain. And so hopefully they'll be able to do stereotactic radiosurgery to these seems like small spots, and then lorlatinib will clean up the rest. And so, radiation necrosis in my practice is still pretty uncommon, and it's only those patients who have lots of brain mets that have been heavily radiated in the brain, but no way to predict that. Ken S. Will RMD be identified via new blood tests or improved testing? I think that's meant to be MRD.
Oh, okay.
Yes.
I was like, oh,
Stephen has a puzzled look on his face.
on this one. So MRD, minimal residual disease, is our way to check for microscopic disease. It's usually done in the setting of someone who's had curative treatment, like surgery or definitive radiation, and it's a way to see if there's any microscopic cancer that's left behind. We know that after surgery for an ALK positive lung cancer, unfortunately, even with chemotherapy, the rate of recurrence is quite high. And so that tells us there's often cancer left behind. MRD is a way to see if there's cancer left behind so that we can identify who needs more treatment, like alectinib after surgery, and who doesn't have MRD, who is completely without signs of cancer. Maybe those patients can be spared. And we do think that it is probably going to be a blood test. There are several assays in development, but we don't have one that's perfect just yet. But a lot of very smart people working on it. Are we supposed to go to those questions too?
Yeah.
Wait, let's not skip Victoria. Victoria,
Yes.
thank you very much for joining.
Yes, thank you, Victoria. Okay, there was a question about frequency of scans, and I think we talked about that a little bit already, right?
Yes.
Or was it the last
yeah.
session?
Yep.
How many ALK patients do you have, and are you taking new patients, Christine? Are you taking new patients?
Always.
All right.
And Nashville's an awesome place to visit, so
Yes.
come visit.
Okay, here's a question. Do you have opinions on the risk-benefit with Xgeva or denosumab for bone metastases? I tried it every 3 months for thoracic pain, where I had a lesion at T5. It increased thoracic pain and caused jaw pain. So I stopped. I'm not sure if protection is worth it. I've been stable on alectinib for 5 years now. Great question.
Yeah, this is a very good question. I would say I usually do start one of these bone medicines for patients, especially if they have a lot of bone disease. Some patients can tolerate it, some patients cannot. I think, one of the goals, if we want patients to do well on medicines for a long time and they have bone disease, I want to protect their bones. And these medicines are the same types of medicines we use for example, women with osteoporosis. And so I do use them. If it's not working for a particular patient, it's not working and we move on. It's not the end of the world, but I do like to use these medicines.
Yeah, I think that if there is jaw pain, I think you did the right thing by backing off a bit. The side effects, fortunately, osteonecrosis of the jaw is a serious side effect, fortunately very rare, but we don't have great treatments for it.
Yeah.
So if there's some signs of problem, I absolutely agree with what you did.
Dental exam before starting the medicine.
Agreed.
Okay, where were we? You messed me up, Stephen.
Sorry, we're
It's
running out
okay.
of time.
I love
I'm
you.
panicking.
Okay. Okay. Let's go back to follow up to Todd's question above. RE timing of TKIs. A new article just shared with this group. Authors speculated the importance of taking a TKI with a full meal might outweigh the time between doses. Thoughts?
I think food absorption for certain medications can be important. I don't know how critical it is here. And so I think that if you're taking it about the same time, that should probably be okay.
Yeah, and some medicines, just speaking in general, some medicines you have to take on an empty stomach, not on a full stomach.
That's
So, I would say, I don't know this article or the quality of the science that went into it. And so I would say follow the instructions from your doctor and the pharmacist that you're working with in terms of whether to take the medicine on a full stomach or an empty stomach, and in general, around the same time-ish every day. The most important thing is take the medicine.
Agreed. Andrea, if someone has MET overexpression, should be treated the same as MET amplification. And is MET overexpression something new that's been discovered? It just seems we're seeing more patients with it.
Yes, we're seeing more patients with this, Andrea, because we're testing for it more. And there's two big principles. This actually came up earlier today in the conference. So we can test for METs. We have 3 minutes. This is, okay, so I'm going to be quick. There's 2 ways we can test for MET. By DNA testing, and that's the amplification, or by proteins testing, and that's the overexpression. There was just a drug approved a little over a month ago now called telisotuzumab vedotin. It's a MET antibody drug conjugate. That's why you're seeing so much literature now about MET overexpression, because the marker for that drug, the Teliso-V or telisotuzumab vedotin, is MET overexpression. So you can test for MET by DNA, you can test for MET by protein. Usually, depending on the level of MET amplification by DNA, usually high levels of amplification by DNA correlates with high level of protein overexpression as well. But they are different tests and different biomarkers for different drugs, and different drugs with whether an oral pill or an antibody drug conjugate. But MET is a very old target. It is not something that's just recently been discovered. It's just the drug landscape just changed, and that's why we're seeing more testing for it. Okay, let's go to the question about lipid panel, just because we are very short, and I think this is an important one. Stephen, do you request a lipid panel as routine blood work?
Absolutely, yes. I think that's an easy one.
Okay, and particularly with lorlatinib.
Yeah, exactly. We know lorlatinib can raise cholesterol. I'm a little bit more worried about triglycerides because that can lead to some things like pancreatitis. When you have a rise in LDL and HDL, we don't know if it means the same thing in terms of cardiovascular risk as someone who develops it not on these medicines, but still we want to bring those numbers down. There are a bunch of questions about weight gain, and GLP-1s and Zepbound. Absolutely, I'm comfortable with that. Other options for weight gain really are dose reduction. I don't think that diet and exercise are going to be effective for these big-time weight gains from a drug like lorlatinib. I don't think that's a viable
frankly,
strategy.
I kind of dislike that. I mean, we should all be thinking about diet and exercise. I dislike when the companies are like, start with diet and exercise.
Yeah,
I mean,
exactly.
It's kind of like scapegoat.
Julie had a quick question. Are all bone medications safe? Yes, I don't have any specific interactions there. Is hormone replacement therapy safe? Yes, I don't have any interactions there.
I would say the hormone replacement therapy, I personally don't prescribe that. I couple with a provider who has more expertise in hormone replacement therapy than I do, with caution. I think this is an evolving, if you're thinking about female hormones in particular for women with lung cancer, because the hormones can be expressed on the lung cancer cells. So I only do that under the care co-management with an OBGYN.
One more question, make it good.
Okay, make it a good one. Let's end with the vaccine question. How do you feel about that, Stephen? It's at the cutting edge. It's kind of towards the bottom.
Yes. So do you have any updates on vaccine efficacy? I think we're referencing Vincent Lam's work, and Marco Wad's early work talked a little bit about some of those things. Christine, is this the future?
Yeah, I mean, I think it's super exciting to think about an ALK vaccine. Vincent Lam at Hopkins has a peptide vaccine, the one that's going to come through the ALK Positive Patient Group, co-sponsored. Breakthrough Cancer Consortia is an mRNA vaccine that'll be starting in 2026. Super excited to see these come to fruition. They're not going to be the magic cure-all. I think they will be an adjunct to current treatments. We're asking a vaccine to do a lot to treat cancer. Usually vaccines are preventing disease, not treating disease. But I think this is a very unique case scenario where we have the opportunity to deliver a vaccine to hopefully ablate minimal residual disease. And we have two different approaches, a peptide-based approach and an mRNA-based approach using the same metrics that were used for the COVID vaccine. The efficacy will take some time to still determine.
I'm sorry we couldn't get to more questions. I feel like we might have started off too slow. That's my fault. These are great questions. Thanks, everybody, for joining.
Thank you so much for joining us today.